Okay, Bismillah ar-Rahman ar-Rahim. If I can invite my moderators, co-moderators, or the faculty to join with their camera and their audio. Welcome, everyone. My name is Muhammad Hassanin. I'm endocrinologist, diabetologist living in UAE, in Dubai. And I'm also the chairperson for the Diabetes and Ramadan International Alliance. It's great pleasure to be with you all for this Diabetes and Ramadan with the IDF workshop on the implementation of the guidelines, kind of like the summary of the guidelines. I'm delighted to have a very eminent faculty with us today. We have Professor Zanaria Hussain from Malaysia, Dr. Suzyani bint Zainuddin from Singapore, and Dr. Rakesh Sahai from India. We're very grateful for the collaboration between DAR and IDF, and for the support from our sponsors from Servier and Sanofi for supporting these guidelines implementation group. So perhaps I would ask our faculty members to welcome everyone in their own words before we run the video for our guests.
Assalamu alaikum and good afternoon to everybody. I'm Zanaria from Malaysia, and I'm very happy to be with all of you this afternoon to emphasize and share the IDF 2021 guidelines, and hope that with this, the efforts to impart the content and train our colleagues in our respective countries. Thank you very much.
Thank you. Good afternoon, everyone. This is Dr. Rakesh Sahai. A warm welcome to all of you who have joined today for this important session we have on the recently released IDF-DAR guidelines on management of diabetics during the holy month of Ramadan. I thank Professor Hussain for having me in this program, and for the excellent efforts he has put in bringing out this important document. Thank you.
Very good afternoon to all. I'm Suzyani from Singapore. So I also similarly like to welcome everybody, and thank you all for taking the effort to actually attend this IDF workshop. I hope that this will be a good way to actually summarize and help you with regards to the recommendations or the guidelines that Dr. Hussain has kindly put in a lot of effort in organizing this.
Well, thank you all. You're all co-authors in this important guidelines, and it's down to your efforts and your research, as well as your services in your centers, that we're able to get this information. I'm delighted that we have as an introduction a video from the president of the IDF, Professor Andrew Bolton, as well as the chair-elect from Bangladesh, from Norway and Bangladesh, Professor Akhtar Hussain. So I will ask the organizers to run the video, the welcome video, please.
Hello, and it's my great pleasure to welcome you to this workshop on diabetes and Ramadan. My name is Andrew Bolton, President of the International Diabetes Federation, and I'm delighted to say that I've been involved with this project really from its inception. The first international meeting of the Diabetes and Ramadan group was held here in my city of Manchester at the Islamic Heritage Centre of the UK back in 2013, when I addressed that meeting as President of the European Association for the Study of Diabetes. But since 2016, International Diabetes Federation has worked very closely with the Diabetes and Ramadan International Alliance to deliver comprehensive guidelines on diabetes and Ramadan. These are designed to help healthcare professionals advise and support those living with diabetes who wish to fast during the holy month of Ramadan. Patient education is, of course, critical to managing diabetes during this period. Educational needs need to be delivered in advance, so today's workshop is indeed timely. Providing education before Ramadan allows for any questions and concerns to be raised and addressed. These guidelines are, of course, of global relevance. We believe that there are probably around 500 million people living with diabetes across the world today, and this figure is set, sadly, to rise. The dramatic rise will be seen in many areas of the world with large Muslim populations, including some of our regions, Sub-Saharan Africa, Southeast Asia, and the Middle East and North African region. Because a large number of people choose to fast during Ramadan, there is a significant need for coherent and evidence-based practical guidance to help them and the healthcare professionals who support them to ensure a safe and healthy fast. As healthcare professionals, we need to understand the potential risks involved in fasting for those under our care. And we need to be well informed so we can deliver the latest evidence-based guidance on medication, glucose monitoring, nutrition, and exercise during this period. This second edition of the International Diabetes Federation and Diabetes and Ramadan Practical Guidelines aims to address these needs by providing the healthcare professionals across the world with latest evidence-based recommendations. It is my sincere hope and the sincere hope of all of us at IDF that these will contribute to supporting people with diabetes to safely and successfully participate in Ramadan should they choose so to do. On behalf of IDF, I really wish to thank my good friend and colleague Mohammed Hassanan from the United Arab Emirates for his tireless work throughout these years and in the editing of the guidelines and the distinguished team that he has gathered with him. I should also like to mention my friend and President-elect Professor Zanaria Hussain for his work done in overseeing this project on behalf of IDF. Naturally, none of this could occur without our friends and partners in both Sanofi and Servier for their generous support in making this possible. And of course, I wish to thank you, the participants, for taking part in today's online workshop. Thank you.
I'm Professor Zanaria Hussain, President-elect of the International Diabetes Federation and Chair of the IDF Working Group on Diabetes Education. It is my great pleasure to welcome you all to this workshop. Fasting during Ramadan is very important practice for millions of Muslims around the world, but can have a major impact on the management of diabetes. While evidence is limited, some studies clearly show that many people living with diabetes choose to fast. The Epidemiology of Diabetes and Ramadan, Epidemiology study performed in 2010 found that about 43% of people with type 1 diabetes and about 79% of those with type 2 diabetes fasted for at least 15 days during Ramadan. Similarly, the 2010 Ckd study reported that close to 95% participants with type 2 diabetes fasted for at least 15 days, and approaching about 65% fasted during the whole month of Holy Ramadan. So we know that people with diabetes will want to fast. However, we also know that an estimated 1 in 3 people with diabetes do not receive the education they need to fast safely. We are here today to help address this shortfall. I'm pleased to report that research on diabetes and Ramadan has increased tremendously over the past 5 years. However, there are still areas where further research will require to improve our understanding and answer some key questions. This can be what, for example, the most effective methods of providing Ramadan-focused education in different populations. What are the best possible nutrition plans for people with diabetes seeking to fast during Ramadan? And how can this be adapted for different regions across the world? Will advances in treatments and technologies help bring us closer to safe management while fasting? For people on insulin therapy who fast during Ramadan, what is the most appropriate type of regimen of insulin? I think we all can agree that diabetes self-management education and support is essential for safe fasting Ramadan. For this reason, the International Diabetes Federation and Diabetes Ramadan International Alliance have come together to raise awareness of the risks associated with diabetes and fasting and deliver the best available advice for health professionals. And this is why we are making the content available to the global diabetes community. In follow-up to the latest guidance you will hear today, we recommend you to visit IDF School of Diabetes website to learn more and access a dedicated free course on diabetes and Ramadan. Thank you all, and I wish you a very successful workshop.
Thank you all for the kind introduction. You have seen the agenda, you've all received the agenda, and I'm delighted that we will be able to start this meeting, this workshop. So I will be starting, and let me share my screen with my presentation. Okay, so we'll start chronologically, where I will look for, in the first session, into the benefits and the risks of fasting, and then share with you the new recommendations for the risk scoring and the pre-Ramadan assessment very briefly. So as you know, this is part of the IDF guidelines, and that section is covered by the co-authors that I have highlighted here in my slide, and I'd like to thank them all for their input into making this section a reality. Ramadan is a holy month for Muslims across the globe. It is the month where the Quran was revealed to the Prophet Muhammad sallallahu alaihi wasallam. It's also the month where we fast, and we are patiently all waiting for that month to come. That is the case for the vast majority of people with diabetes as well. But obviously for some, it could be a bit of a challenge. Ramadan is not just a spiritual month. It's a month where any of the good deeds will count and are encouraged by so many people. But also it's a family and community time where people meet together, they do lots of activities together, they share meals, and they get together. So with all this, there is an atmosphere of happiness and better mood. Having said that, for some people with diabetes, that could be an atmosphere of perhaps frustration or stress or anxiety. We have seen from data that there are benefits for fasting for people with diabetes. We have seen recent data suggesting that there is a modest weight loss. There are improvements in the biometric and the measures such as blood pressure and weight I've mentioned. The biochemical parameters as well improve. HbA1c and lipids profile improve. And this reflects on better parameters for fatty liver disease. Unfortunately, the fast is only for 1 month, because a few weeks later after Ramadan, these positive effects disappear. But we should not forget that for some, there is hypoglycemia, there is hyperglycemia, perhaps for some associated with ketoacidosis, and there is the potentials for dehydration and the theoretical problem of thrombosis. So we need to try to find who are these people who get these problems. In the previous guidelines, we had a table of the groups that are very high, the groups that are high, and so on. But we found that many people are giving us the feedback, or from clinical practice, that we're saying they are high, but nevertheless, they are fasting. So it became clear that we need to look more in depth into how we can individualize the risk categorization. And I would like here to share some of the points that are really important. So if you look here to a study that myself and Dr. Sahoo are co-authors in, it's a study called Orion study, which is on Glycemic 300. And this particular trial looked into observation of what happens for nearly 500 persons. The vast majority of them are from Middle East or North Africa or India and Pakistan. Small group are from Canada. As you see in the graph here, the rates of hypoglycemia in Canada is nearly a quarter of the population, while in other regions, it was quite a very, very low rate of hypoglycemia. So the difference, we think, could be a number of factors. Could be related to the duration of the fast. Being in Canada, in the Northern Hemisphere, the duration of fast is longer. Perhaps it is the other factors as well. How are the hours of work modified or not? Certainly, personally, when I was living in UK, no modification of work pattern for a person fasting Ramadan. But in many countries, in Muslim majority countries, that is adjusted for, and so on. So you need to think of these circumstances. Another important point is the type of diabetes. When you look here into the difference between type 1 and type 2, for the decision of fasting, so 30% of people with type 1 diabetes decide, I do not want to fast. Well, this is only 16% in type 2. And you can clearly see that for many people, the rates of hypoglycemia between type 1 and type 2 are very different. 62% daytime hypos in type 1 versus 15% only in type 2. So it is really quite important that we all remember all of these points when we are thinking of our people with diabetes. But it is all not doom and gloom. There are some people with type 1 diabetes who are able to fast for the full month and without hypoglycemia. So the glass is not half empty. Perhaps the glass has some water, and that's how we should describe it. When it comes to type 2 diabetes, the type of therapy is quite important. Being on oral therapy only, or oral therapy that does not include sulfonylurea, is with lower risk of hypoglycemia versus those who are on insulin. So that is quite important, and that was evident in many of the recent studies. Another very crucial point, as you see your patients currently, knowing whether they have hypoglycemia or not is very important. Because if they are having hypoglycemia currently, then the risk of hypoglycemia during Ramadan fast is much higher. And that is something we need to address and to try to quantify for. What about comorbidities? Well, this is an example from a study that we did in Dubai Hospital, where we provided our patients with stable coronary heart disease, with education, with the best insulins, as well as with flash glucose monitoring. There was no change to the cardiovascular risk parameters. There was no increase in cardiac events, but there was a significant increase in hypoglycemic episodes. And that's quite important for us to remember. What about age? Does age matters? Well, my advice to you very briefly, this will be addressed later by my colleagues addressing this special population. The answer is yes, and that's important for us to remember. I will not dwell too much on this because this will be covered later. So we have the new risk score, which includes multiple parameters. For every one of them, there is a score. Type of diabetes, duration of diabetes, hypoglycemia, glycemic control, type of therapy, the presence of chronic complications, whether macrovascular or renal, acute complications, whether the lady is pregnant or not and in target or not. Having said that, it's important to remember, any pregnant or breastfeeding lady is exempt from fasting regardless whether she has diabetes or not. And that's important to reinforce. Self-monitoring is really crucial because it is the tool to detect and prevent the problems, hypo and hyperglycemia. And indeed, whether the duration of fast, as mentioned, the intensity of the job that a person is doing, the social circumstances, whether I live on my own and maybe I'm in my 70s, as well as frailty and cognitive function. And finally, the previous experience of the individual on whether this previous Ramadan was pleasant or not. Based on all this, you will put a score and you will end up with green, red, or amber. And you need the harmony with the religious authorities. And that harmony is provided from the fact that our current guidelines has the approval of the Mufti of Egypt, the highest religious authorities there. Of course, you will need to take that into your local society to get the local approvals. The religious authorities base their opinion on the scientific material we provide them, as well as the principles in Islam of avoiding hardship and eliminating potential harm. These two aspects are repeatedly stressed upon in the Quran verses as well as in the Prophet Muhammad ﷺ teachings. So based on this, people in green, they have to fast. If you as a clinician feel they must be eating or drinking frequently because of another issue, or they must be taking regular medication during the fasting hours, then they are exempt. People in the moderate risk category, they are advised to fast. However, if you feel that based on their score, the risk is high and you've addressed all of the issues, then they are religiously and scientifically exempt from doing so and can indeed stop the fasting. If they decided to fast, they really need to follow the recommendations that you provide very carefully. Of course, those who score high in the red are indeed advised not to fast. So you need the assessment before Ramadan. You need to look into all the aspects sequentially, put an initial assessment score, and then discuss with your patient what measures could be done to perhaps modify that risk level, because obviously it's a dynamic situation. I hope that this risk tool will be available for all of us online, on the IDF site, on DAR site, as well as on DAR application. So it's very important that we have the assessment before Ramadan and to address all of the important issues. Education is key. We are all together today to improve our knowledge and skills, but we should not forget that this needs to extend as well to religious and community leaders. An advice in a media venue or in a mosque by someone who is not well informed could lead to the opposite outcome that we wish. However, the most important education is that directed to our patients, and that's really is quite key. Education works, and the meta-analysis is saying to us that it improved glycemic control, even though we are talking about glycemic control for the month of Ramadan, which is only 4 weeks. So it is important that we address all of these aspects, and all of this will be addressed in our future, in our next sessions over this morning or afternoon for you. SMBG, as I mentioned, is key. We're not saying do 7 times a day. The frequency and the timing will be dependent on the own individual case, including all of the aspects that we've just mentioned. But regardless of how frequent, don't forget the most vulnerable time is late afternoon to evening, between Asr time and Maghrib time. That's when the body stores of glucose are exhausted and perhaps the medication are still kicking in and can put the person at risk of hypoglycemia. Recognizing the symptoms of hypoglycemia or indeed of hyperglycemia is crucial, because if the person feels these symptoms, then of course they need to stop the fast if they do not have the means to check. If they have the means to check, of course, that would be superior. So education during the COVID time is really quite important, specifically when we are talking about virtual. I'm delighted that we have the IDF-DAR module, which was very successful this year and last year, and this year will be running as well. But also we have the app and the online of DAR, which provide lots and lots of information for our healthcare professionals and more importantly for our patients. So in summary, ladies and gentlemen, we all know that fasting during the month of Ramadan is a religious obligation. But we also know that unhealthy individuals, those with illness, could be exempt. Our job as healthcare professionals is to look into the various risk aspects of the individual, the various parameters of their diabetes and their health in general, and then provide them with a risk score. If after our risk score they insist on fasting, then it is really quite important that all measures are undertaken to try to minimize that risk. Among these important measures is the pre-Ramadan assessment and education. And with that, I would share with you the latest references. Obviously, the ultimate reference is the guidelines itself, which is a free download on the website. And I would like to thank you and stop sharing here. So I'm delighted that we now can move to the following session, and I'm really grateful for the faculty that we have today. Our next session is by Dr. Zanaria Hussain, who will be addressing the important topics of the pre-Ramadan nutrition, the education assessment, as well as the oral therapy. I'm sure you all in Asia know Dr. Zanaria Hussain, who's a consultant endocrinologist, who's the head of the endocrine unit at Putrajaya Hospital, and she also was the ex-chair of the MEMS. She is quite eminent in the field of Ramadan and diabetes research in general, and she has been collaborating with many of us on research in diabetes and Ramadan. I think I'm delighted to introduce
Dr. Hassanin and everybody, thank you for the kind introduction. Just a little bit of correction. I'm actually doing the section on the special populations, which is
you know what?
Session 4.
When I was introducing you, I felt that is out of sequence. So I'm just relying on my fading memory. So I'll leave you to introduce our next speaker now.
Okay. All right. So the next speaker that I will introduce is my colleague from across the border from Malaysia, which is Dr. Suzyani Zainuddin. And I'm so glad we were able to collaborate together to make this workshop and the following training, the trainer session after this, possible this afternoon. So I'd like to invite and welcome Dr. Suzyani to share with you the highlights and recommendations from the section of the management of type 2 diabetes in Ramadan, with a focus on the oral hypoglycemic agents as well as the injectables, particularly the Glp E1 receptor analogs. Welcome, Suzyani.
Hi, good afternoon to all. So I'm covering the highlights as mentioned by Dr. Zanaria on the management of type 2 diabetes. All right, so I'd like to acknowledge the following contributors to the corresponding chapters on the full version of the guidelines. So this outlines my talk. I'm actually going to cover on nutritional changes in Ramadan, the adjustment necessary for oral diabetes medication, Glp E1 receptor agonist, and also what to do for patients on multiple therapies. So nutritional changes in Ramadan. So as for the last time, that RP is recommended, and since then, many more menus and meal examples have been developed for different countries, and there's been greater evidence for the up-to-date nutritional advice for people with diabetes seeking to fast during the Ramadan period. Because we hope that more and more countries will be able to contribute to RMP to enable contextualized guidance for those individuals without access to healthcare professionals immediately before Ramadan. So what are some health issues related to nutrition during Ramadan period? We know that there are changes in daily routine during Ramadan, which results in changes in dietary as well as activity patterns, and this can result in health issues. Common unhealthy habits during this period are related to the changes in the meal components and timing, as well as the activity patterns. As shown here, these include consumption of meals which are too large portion at Iftar, desserts which are high in sugar, as well as highly processed carbohydrates and fried foods during the non-fasting hours. In addition, there'll be people who eat too fast, who do not allow satiety signals, which takes about 30 minutes to set in, and hence this leads to overeating. Together with changes in physical activity and sleeping patterns, these have an impact on metabolism, and this leads to weight gain. It is also best to eat sahur as late as possible, especially where the fasting duration is more than 10 hours in order to last the whole fasting duration. So, Dr. Muhammad had already mentioned that pre-Ramadan assessment is a very crucial time, and this should be done about 6 to 8 weeks prior to Ramadan, so about this time. And when the pre-Ramadan assessment is done, this should actually include a guidance on medical nutritional therapy. This seeks to improve the glycemic control, to prevent dehydration, as well as other diabetes-related complications, and provide an individualized nutritional plan. This helps to allow the individual to feel more energized and achieve successful weight loss if that is their final goal. In addition, this is actually an opportune time to use discipline to start a new habit of adherence to this particular goal. Prof. Nisak had already shown that this improves fasting blood glucose, triglycerides, and rate of self-monitoring of blood glucose. So the main aim of the medical nutritional therapy is to ensure adequate amount of calories with balanced proportions of macronutrients are consumed, equal distribution of carbohydrate intake amongst the meals, MNT plans which take into consideration comorbidities for those who have hypertension and dyslipidemia. As mentioned, it is also the best time for those who are obese or overweight to aim for weight loss in order to improve glycemia and cardiovascular risk, with an optimal target of about 0.5 to 1 kilogram per week of gradual weight loss. This recommendation for caloric targets take into account the gender, with a higher caloric aim for men, up to 2,200 kilocalories for weight maintenance, or lower at 1,800 for those who are aiming weight reduction. And for ladies, it is based on the height, up to 2,000 kilocalories for women who are more than 150 cm tall, for weight maintenance, and lower at 1,500 for weight reduction. And of course, for those who are shorter, a weight reduction will be to aim the total calorie intake to 1,200 per day. There also needs to be carbohydrate distribution between the meals, with about 40% of calories at the two main meals, Sahoo and Iftar, and about 10 to 20% of the calories at the two snacks, if the patient considers taking snacks after Iftar or during the non-fasting hours. So this is the Ramadan nutritional plate, which is recommended, and you can actually access this via the toolkit in the website that's written here, the DAR Alliance website. It is also available through an app for healthcare professional to use, as well as for the patient, in order to guide them as to the kind of meal plans that can be used for the different cultures. So if you actually access the website or the app, you can actually see that there are various meal plans suggested for the various countries. So in our region, it will be Malaysia. I think Indonesia is coming up. It's not actually available yet online. So for us, we can actually use the Malaysia one to actually consider for patients, go through the possible meal planning for patients, or if the patients themselves can also show how to actually use it. So I'm going on to the next section, which is the timing and dose adjustment of oral diabetes medication for type 2 diabetes. So this is also needs to be done at the pre-Ramadan assessment. So that for type 2 diabetes patients, they are on different treatment regimens to target different mechanisms. And different treatments have different potential risks, and hence the recommendations have to the main concerns during the fasting is with regards to glycemic control, as well as risk of hyperglycemia. Of that is indicated here, that those which have a higher hyperglycemia risk will need more attention of these dosages and these treatments, regimens, metformin, sulfonylureas, insulin secretagogues, insulin will need adjustment to reduce hypoglycemia risk. Dr. Rakesh will be covering on insulin, hence I will not be covering that in this session. Of course, other than dose adjustment, we do need to make sure that the patient continue to monitor, do self-monitoring of blood glucose in addition to. All right, so let's look at the various medications. So for metformin, the most commonly used treatment for type 2 diabetes for inhibiting hepatic gluconeogenesis, and it is available in an either immediate release preparation up to thrice daily or once daily prolonged release formulation. Although we know that severe hypoglycemia is rare in metformin use, even in non-fasting individuals, and there are no RCTs for use during Ramadan fasting, it is considered safe for individuals on metformin therapy to fast, monotherapy to fast. Those adjustments is actually recommended only for those who are using metformin thrice daily dosing, such that the afternoon dose has to be combined with the dose at iftar, keeping the morning dose the same at sahur meal. How about acarbose? So we know that acarbose inhibits the action of alpha glucosidase, and so slows down glucose absorption. As the risk of hypoglycemia is low, and whilst there are no RCTs conducted in Ramadan fasting, no dose modification is considered necessary in this patients taking acarbose. Okay, so the next I'll be covering is on thiazolidindiums. It actually improves glucose uptake and utilization. And the risk of hypoglycemia in non-fasting people in its monotherapy is low. So there is no need for any dose modification used, performed during Ramadan, but the dose should be taken ideally with iftar. How about short-acting insulin secretagogues? You do know that this actually is rather short-acting and is taken just before the meals. So for those who are on thrice meal dosing, the dose can be either reduced or redistributed to 2 doses during Ramadan according to the meal sizes. Okay. So how about DPP-4? You know that this actually improved the glucose based on reduce the in a glucose-dependent manner. They reduce the insulin secretion in a glucose-dependent manner. So there are enough. There are various RCTs as well as different studies which have shown that we do know that DPP-4 amongst the treatment that do not actually cause hypoglycemia, so they actually do not require treatment modifications during Ramadan, as shown by the RCTs here. How about sulfonylureas? So a few studies have actually shown the comparison between the various sulfonylureas, as shown here by Aravind. There's actually highest incidence of hypoglycemia in glibenclamide use and least in glycoside use. Similarly, when it comes to glycoside, it is shown that there are no severe cases of hypoglycemia in use when it comes to usage of either glycoside or glycoside MR. And so the recommendations is such that when it comes to use of sulfonylureas, it is recommended that rather than the older drugs such as glibenclamide, which carries a higher risk of hypoglycemia and should be avoided, second generation sulfonylureas such as glycoside or glycoside MR should be used instead. For those who are taking once daily or twice daily dosing, it is best to take the sulfonylurea at iftar. For those who are well controlled, for those who are on twice daily dosing, the iftar dose can remain the same. However, for those who are taking once daily dosing, there will need to be consideration for reduction of dose at iftar. For those who are taking twice daily dosing, the sahur dose should be reduced in order to avoid hypoglycemia. How about SGLT2 inhibitors, which is the newest oral diabetes medication? There are several studies that have been done, and the concern was that whether in fasting, this will actually result in increased dehydration and fluid depletion during the fasting hours. However, it has been found that for stabilization, SGLT2 should be initiated at least 2 weeks to a month prior to Ramadan. It's best to be administered at the time of the evening meal, which is at Iftar, and increasing fluid intake during the non-fasting hours during Ramadan is recommended, as SGLT2 has a low risk of hypoglycemia, as shown in the previous studies. No dose adjustment is required during the Ramadan period. We do know, however, that there are more recent studies that shows that there is good cardiovascular benefits in terms of heart failure as well as renal function, and hence these should be taken into consideration when choosing an oral diabetes medication. And the changes in these recent guidelines should be made aware amongst the physicians, and the use of SGLT2 as a medication even during fasting should be in accordance to the usual safety measures, and also taking into consideration the patient risk profile, I hope. So the last medication that I'll be covering will be Glp E1 Receptor Agonist. So we do know that the risk of hypoglycemia is low in Glp-1 receptor agonists, as been shown in studies on lixisenatide, liraglutide, and also exenatide. However, when used in combination therapy together alongside with sulfonylureas, this can actually increase the risk of hypoglycemia. It is best that these medications are appropriately dose titrated prior to Ramadan, at least 2 to 4 weeks prior to that. Thereafter, no further treatment modifications is required during the Ramadan period. How about those who are on multiple diabetes treatment? What should be done for them? So these will be the ones where a lot more attention will need to be taken into account. They are at higher risk for hypoglycemia during the fasting, during Ramadan fasting. This is especially so in patients who are on 3 or more diabetes agents, as also shown in the previous study. So they do need to receive counseling and comprehensive advice on diet, lifestyle, and drug dose modification prior to Ramadan. In addition, Dr. Rakesh will cover more about insulin adjustment. However, those who are on 3 or more drugs combination, together with insulin and sulfonylureas, due to the increased risk of hypoglycemia, we'll need to consider a reduction of the dose of insulin up to about 50%, depending on the risk score that is determined after the risk stratification. Continuous glucose monitoring as well as activity monitoring could also be used to harness to reduce the risk of hypoglycemia in these patients who are on multiple antidiabetic agents and fasting during the Ramadan period. So we've come to the end. So just as a summary, so I mentioned about RNP, which can be used to individualize and implement MNT. It also helps individuals who may not have access to healthcare professionals. The various treatments for diabetes type 2 has various risk profiles. And so patients who are on metformin, sulfonylureas, insulin, secretagogues will need to make those adjustments, especially so for patients on combination anti-diabetic therapies, and especially for those who are on 3 or more drugs. It will be best to get them to come back post-Ramadan to reassess their treatment regimens and also fasting experiences to plan further. And we do know that with the adequate advice and support from healthcare professionals, most patients with type 2 diabetes can fast safely during the Ramadan period. So these are the references for the talk, and the full reference is available in the guidelines. Thank you.
Thank you very much, Suziani, and my apologies for not introducing you and the wrong sequence. but we've all listened to how can we best manage our patients on oral therapy or indeed on GLP-1s. And we now move to the following session, which will be delivered by my good friend, Dr. Rakesh Sahai. Myself and Rakesh have collaborated on a number of clinical trials. We co-authored together a number of clinical trials. He is quite well known for his work. He's a professor and head of department of endocrinology at Osmania Medical College and Hospital. He's a consultant endocrinologist in a number of hospitals. He is the president-elect for Endocrine Society of India and been involved in a number of societies regionally and nationally, and with huge number of publications, over 130 publications into the various regional and national and international medical journals. Rakesh, over to you to address the issue related to insulin management for during Ramadan, please.
Yeah, thank you, Professor Hussain, for the kind words of introduction, and thank you for having me today in this program. It is indeed a pleasure to be here to discuss about changes required in therapy, the risk assessment of people on insulin, and also the way in which the insulin therapy has to be adjusted during the period of Ramadan. So I would be discussing about injectable therapy, particularly with focus on insulin therapy, as my previous speaker has spoken about GLP-1 therapy. I would also be speaking about the combination of insulin and GLP-1 RA therapy. So the major questions that I would be trying to answer during this presentation is about the evidence for the use of insulin during the holy month of Ramadan. Insulin analogs versus human insulin, how do they fare? Do analogs do better? What are the advantages of analogs using analogs in this period? Which regime to use? And how do we adjust insulin doses at the start of the Ramadan month? And how do we titrate the doses during Ramadan? And what is new with regard to the guidelines that have come out recently? So the major difference, as Professor Hussain has shown us, is that the guideline is no longer speaking about, the risk stratification is the major change in this guideline. We have moved from the earlier risk stratification from very high risk and moderate risk and to actually giving a score for various aspects, because what we have realized over the years is that several individuals who were categorized in a high risk were actually insisting on going to the fast, and they were able to go through the fast without much of a problem. And so there was clearly need felt to categorize or objectivize this risk stratification, and that has been very elegantly done in this guideline. And as you can, as Dr. Hussain has already given us a clear sort of overview about this risk stratification, I would just like to highlight a few aspects of this risk stratification. That is, when you're looking at diabetes treatment itself, we're looking at patients who were earlier in use of insulin itself, who used to put patients in a very high risk. But today, in the new risk stratification, we are looking at sort of objectivizing the type of insulin that is being used, with the use of basal insulin providing the least sort of increase in risk. That is categorized as 1.5 points, and you have got once daily mixed insulin, then you've got basal bolus therapy, and then those patients who are on multiple pre-mixed insulins. So this is how the risk stratification is different from the previous guideline. And as you can also see that patients who are on different OADs are also stratified based on the type of OAD that they're using. Those using SUs probably have the highest risk, and those who are on OADs other than SUs probably have a low risk, and they're put as the risk scoring is put as 0. Now, if you look at the data from the DAR study, we have clearly seen that the presence of diabetes itself increases the risk of hypoglycemia during the month of Ramadan. And this was, but if you then stratify the patients with diabetes into those who are using OADs without SUs, the increase is probably a minimal increase. Then you look at patients who are on OAD plus SUs, OADs including SUs, they have probably a higher risk than as compared to those who are on other OADs. And then in the use of insulin obviously increases the risk of hypoglycemia to greater extent. So therefore, there is a need to stratify the type of treatment that the patient is on, and the risk scoring can then be based on this on the type of medication that the patient is on. Now, Dr. Hussain has also spoken about his recent publication where they have provided optimal care to patients with diabetes who are fasting during the month of Ramadan, and they've looked at the comparison. In this study, they've looked at the comparison between the use of basal insulin versus intensive insulin. So, as I was mentioning earlier in the previous slide, that the use of basal insulin probably increases the risk of hypoglycemia to a much lesser extent as compared to those who are on intensive insulins, either basal bolus therapies or multiple doses of premixed insulin or other types of insulins that when they use, they're probably at a higher risk as compared to basal insulin, as was clearly shown in this study, where you could see that the risk of hypoglycemia is higher, clearly higher in the number of hypo events, although not statistically different, but they are numerically little more in the patients who are on intensive therapies as compared to basal insulin therapy. The duration of hypoglycemia also was lesser with the basal insulin therapy as compared to those who are on intensive insulin therapy. So clearly there is a need to look at what type of insulin that the patients are on, and preferably when you're starting off insulin, even prior to Ramadan, it may be good to look at patients who would benefit from the use of basal insulin alone, and the risk of incremental risk in terms of having the fast during the month of Ramadan is probably going to be much lesser. So, but the important issue is that we need to individualize the insulin therapy for every patient. It has to be individualized based on the patient's several characteristics of the patient, depending on the glucophenotype of the patient and the type of insulin that the current type of therapy that the patient is on. If he is on basal insulin therapy with a long-acting analog, probably there would be no need for a change in the insulin. Also, the doses and the timing of insulin also may not require much change if the patient is on a bedtime insulin with a long-acting analog insulin. Then probably there's no need of change required. But those on premixed insulin require much more changes in terms of their doses, as I will be discussing in the subsequent part of my presentation. And then the timing of doses need to be adjusted. There could be a change in the type of insulin that we also look at, and a combination with other therapies also needs to be looked at. And so these are all the issues that have to be looked in when you are trying to individualize the therapy in a patient who is planning to fast during the month of Ramadan. The practical considerations that we need to keep in mind is that most patients would elect to fast irrespective of the risk level that we have put them in, and we need to advise them accordingly. And many times, as mentioned earlier, that we need to advise those with the moderate risk. We need to plan their therapy and make appropriate adjustment in their therapy so that they have a lower risk of having hypoglycemia during this period. While the primary focus is always on the risk of hypoglycemia, care should also be given towards improving the glycemic control during this month of Ramadan. The insulin regime should therefore be individualized by taking into account the education, the level of education of the patient, the preferences of the patient, the diet and his lifestyle, and there could be a justification even to switching from twice daily premix to intermediate acting insulins to longer acting analog insulins in the evening, and avoiding and taking the rapid acting insulin along with meals in the evening. So this way you would need to individualize and modify the insulin regimes in most of our patients. Changing the regime not only during this, just doing it for the month of Ramadan may lead to more errors. Patients may have more confusion. They have a higher chance of non-adherence, and they require more education during this period, which may at times not be readily available, and therefore it may be good to think of the Ramadan month even prior to Ramadan, whenever patients intensification of insulin therapy is done, or when the patient is initiated on insulin prior to Ramadan. Also, we could keep in mind how the adjustments could be done during Ramadan, so that the patient can go effortlessly through the month of Ramadan without much of adjustment being required prior to Ramadan and even during the month of Ramadan. So this is what we should keep in mind whenever we are initiating insulin in a patient. Maybe a couple of months before Ramadan, if we are planning to initiate insulin, then we could look at the patient's intent to fast during the month of Ramadan, and look at appropriate initiation of insulin, which could be suitable during the month of Ramadan also. So if you look at the data that we have several observational trials which have demonstrated safety of particularly about basal insulin. If you look at trials of basal insulin, we have different trials where basal insulin has been used in combination with oral anti-diabetic medications, and in combination with rapid-acting analog insulins. And what these trials have shown, if you look at some of these trials, the first one is a small trial of 19 patients, which reported no significant difference between the two groups with the use of basal insulin versus other insulins. Whereas if you look at the second one, which was from Sati et al., they had observed 412 patients during the month of Ramadan from several countries, that is Bangladesh, China, Egypt, India, Indonesia, Kuwait, and Jordan. There you see that they had compared. They had no comparator group, but they looked at the use of basal insulin analog insulins with additional use of sulfonylurea, metformin, and what they have shown is that during the month of Ramadan there was an increase from pre-Ramadan to Ramadan, which was statistically significant, the increase in hypoglycemic events, and there was a reduction in the events in the post-Ramadan period. And there was no major change observed in terms of the glycemic control. But we have the other trials which have looked at, again, U100 glargine, which has shown that individuals experienced no significant difference between the use of between the pre-Ramadan period and during the Ramadan period in terms of the hypoglycemic events. However, there was no change in the body weight also during this period. We have an interesting study of U300 glargine, the Orion study, in which I was a co-author along with Professor Hussain, and we had observed 1,214 patients who were from different countries across this region who were on U300 glargine, and the good part of this study was that there were no severe cases of hypoglycemia noticed during Ramadan or in the pre-Ramadan period, and the HbA1c improvement. There was also a HbA1c improvement to the tune of 0.3% with the use of U300 glargine, and body weight also decreased by 0.5 kgs, which was also statistically significant. So the use of U300 glargine did show that majority of patients fasted for the whole month of Ramadan, and there was low incidence of symptomatic hypoglycemia and no episodes of severe hypoglycemia. There was it also demonstrated that glycemic control could be successfully intensified during the month of Ramadan. So the use of basal insulin clearly has been shown in all these studies to provide a very low risk of hypoglycemia, and the use of U300 glargine has particularly shown that there was no increase in the risk of hypoglycemia, and there were no episodes of severe hypoglycemia during this period. Now, what about combination of basal insulin plus GLP-1 RA? We have two interesting studies. The one with liraglutide, where liraglutide was added, which was used along with degludec, was an observation study with 111 participants. 16.2% of patients experienced events. A small but significant increase in HbA1c was observed during the month of Ramadan. While the lexistinotide study, where addition of lexistinotide to glargine was compared to addition of SU to glargine, we had 184 patients in this study, and we clearly showed that there were lower rates of any hypoglycemia versus versus sulfonylureas as compared to addition of sulfonylurea as compared to addition of lexistinotide. Did show clearly lower rates of hypoglycemia during the month of Ramadan, and there was a reduction in the HbA1c from baseline to the post-Ramadan period. As you can see here, the LixiRam study showed a clear increase, lowering of the risk of hypoglycemia. The odds ratio for hypoglycemia was much lower, whether you look at any hypoglycemia or and whether you look at on treatment period, pre-Ramadan period, or during the Ramadan fast, you find that there was a clear reduction in the rates of hypoglycemia, and the odds ratio clearly favored the use of lexistinotide in addition to basal insulin as compared to SUs being added to basal insulin. If you look at the use of analog premixed insulins versus human insulin, this study of by Akram et al. Has compared the use of analog premixed insulins to human premixed insulin, and they clearly showed that there was the events per individuals on insulin lispro had fewer events than people, fewer hypoglycemic events than people on the premixed human insulin, and the glycemic control was also better in terms of reduction in the 1 hour and 2 hour postprandial glucose levels were lower in the group that was receiving proterminated lispro as compared to the one that was receiving in premixed human regular insulin. So the advantage is clearly in terms of the reduction in the postprandial hyperglycemia, which is again a factor that has to be kept in mind. And insulin analogs, therefore, injected just before a meal or even after a meal at the time of Iftar and Sahoo, instead of being used much earlier, that is 30 to 40 minutes earlier with the need to inject it earlier with human insulin, they provide better control of the postprandial hyperglycemia and afford also lower rates of hypoglycemia. Premixed insulins are the commonest regimes used in most countries, and what we see is that the use of low ratio premixed insulins as compared to the high ratio premixed insulin. This was an interesting study. If you look at the one from Hu et al., they looked at insulin lispro mix 50 in the evening and lispro mix 30 in the morning, and they compared it to comparator was human premixed insulin. And clearly, the hypoglycemic events during Ramadan and during as compared to in the previous month of Ramadan were lower with the lispro mix 50 as compared to the human premix. And the HbA1c change within the groups were associated with there was a decrease in the HbA1c to the tune of 0.49% in the group that was receiving the analog premixed as compared to the group that received human premixed insulin. And however, there were no significant difference in the weight change between the two groups. The other study looking at by Sowandu et al. Showed that there was when they looked at insulin aspart and compared. They looked at the use of aspart in terms of the number of hypoglycemic events. There was no clear difference in terms of the hypoglycemic events, but there was improvement in the postprandial glucose levels, particularly the 2 hour postprandial glucose levels, with no significant changes in body BMI observed during the period of use during the Ramadan month. So we have the option of using a higher ratio premixed insulin at iftar and changing to alternative regime, that is basal plus prandial or basal plus GLP-1 RA, rather than using a premixed insulin, because that increases the risk for hypoglycemia during the fasting hours of during the month of Ramadan. So with regard to the use of the new co-formulation that is available in most of the countries, IDF-ASP, this has been studied and has shown that it could be safely used in the month of Ramadan. There's statistically lower incidence of oral hypoglycemia, almost a 74% reduction in the risk of hypoglycemia, and it has also shown a clear glycemic benefit, as can be seen from these two studies. So coming to having looked at all this data, let me now summarize this and summarize the changes that need to be done in terms of the insulin use during the month of Ramadan. So if you're looking at those patients who are using pre-mixed insulin during the Ramadan month, if they're using once daily dosing of pre-mixed insulin, we do not need to do much of a change. They can take the same normal dose at iftar. Those who are on twice daily premixed insulin, they could continue with the normal dose at iftar, and they can reduce the suhoor dose by 20 to 50%. In fact, they could take the usual morning dose in the evening prior to iftar, and they can reduce the evening dose, the pre-Ramadan evening dose. They can shift it to suhoor and reduce it by 20 to 50%. Those who are on 3 times daily premixed insulin, that is the greatest challenge, because they will not be able to, they have to omit the afternoon dose of premixed insulin, and the adjustment for the iftar and suhoor doses has to be done as mentioned earlier, that the morning dose prior to Ramadan has to be shifted to, should become the pre-iftar dose, and the evening dose taken prior to Ramadan has to become the, will become the pre-suhoor dose, with a reduction in the dosing by 20 to 50%. And then titration of the dose is very important. And during the month of Ramadan, the titration is very important. Fasting glucose levels, pre-iftar levels, and pre-suhoor blood glucose levels are going to be very helpful in deciding and adjusting the dose, as shown in this table here. It is suggested that dose in the range of 90 to 20, the target should be to keep the glucose levels in the range of 90 to 126. As they're going down, we reduce by 2 to 4 units, or when they're going up, you reduce by 2 to 4, increase by 2 to 4 units as they go. When very high doses of insulin are used, a change of 10 to 20% of the dose may be more meaningful dose change rather than doing by 2 to 4 units. So these are the major changes that need to be done when you're looking at using a premixed insulin. So when long-acting or intermediate-acting insulins along with short-acting insulins are being used, so the changes that need to be done would be that you need to, for long-acting basal analogs, those who are on a analog insulin, a basal analog like Glargine or Degludec, when they're taking it once daily, you don't require a change in the dose. You can continue to take it in the evening. But those who are on the NPH insulin, NPH once daily, you may adjust it to take when they're on NPH, you would prefer to reduce the dose by 15 to 30%, take it at iftar, suggest them to take it at iftar, and NPH or Detimir, when it's taken twice daily, take the usual morning dose at iftar, reduce the evening dose by 50% and take it at suhoor. So that's the advice that would give them for those who are on twice daily NPH. For those on short-acting insulins, the normal dose at iftar can be continued. They omit the lunchtime dose and they reduce the suhoor dose by 25 to 50%. And once again, titration during the month of Ramadan is very important. The titration for basal insulin could be again done as recommended in this table here. And for the short-acting insulins, you would need to look at the pre-iftar levels and the pre-suhoor levels and decide on the titration. For those on insulin pump during the Ramadan period, they may require a change in the basal rate. They reduce the basal rate by 20 to 40% in the last 3 to 4 hours of fasting, particularly in the evening hours, late afternoon hours, the 3 to 4 hours before iftar. It is important to reduce the basal rates during that period. And we may need to increase the basal dose by about 20% early after iftar. For the 3 to 4 hours after iftar, it may be important to increase the basal rates while reducing it in the pre-iftar period. For the bolus rates, the normal carbohydrate counting and insulin sensitivity principles have been used prior to Ramadan would continue to be used. The same has to be followed during the month of Ramadan. But the important aspect is education, and appropriate patient selection is very important. The use of pump certainly allows reduction in the risk of hypoglycemia and hyperglycemia, and patients should be also motivated and educated about the use of the pump, and the use of the automated pumps, the new generation automated pumps can be very beneficial during the month of Ramadan, because they have the auto suspend and other features which would even sense hypoglycemia when it's occurring, even when the rates of blood glucose are falling, even before they reach the level at which the cutoff is done. Even when the rates of fall in glucose are detected, then the basal dose is cut off and suspended, and the patient is protected from hypoglycemia. So these sensor augmented pumps and closed loop automated insulin delivery systems are very helpful in reducing the risk of hypoglycemia, even more than what we could do with the earlier generation pumps and what we achieved with the other forms of insulin. The most important point that has to be highlighted to all patients who are fasting during the month of Ramadan with the use of insulin, they should be encouraged to monitor regularly, particularly these different time points, as Dr. Hussain has highlighted, that it is very important to do the 7-point monitoring. And particularly if you look at the very important ones, the important ones are the ones in the late afternoon and evening prior to iftar, and this is the time when hypoglycemia occurs to the maximum extent, and it is important that patients monitor their glucose levels at that time. And if they're able to use continuous glucose monitoring systems, which are now available, they would make it very convenient for the patient and for the healthcare providers to adjust the doses of insulin, and can provide them a very safe insulin regime to be used during the month of Ramadan. So a trial fast done for 3 days before Ramadan is particularly useful in patients who are on insulin, because this could help them in terms of detecting the hypoglycemia risk. It may guide them in terms of titration of the insulin doses, and it may help them to identify fasting or postprandial hyperglycemia that may be occurring, and it could help them in making appropriate adjustments in the dose. Careful extrapolation of this information is required owing to the differences in the length of the fast in different parts of the world. So we need to use this information which you just presented, but apply it according to the length of fast in different regions. It is important to apply that, to keep that in mind when we are using this information. And doing a trial fast particularly is going to be helpful for those patients who are on insulin during the month of Ramadan. So in summary, I would say that insulin can be used safely in appropriately selected patients. There is no evidence. Now we have evidence for the use of safe use of the new analogs of insulin like the U300 glargine and idagasp, which have shown to lower the risk of hypoglycemia much lower than what was seen with other types of insulins. Insulin therapy must be individualized for patients, considering the baseline control, the education, the preferences of the patients, and their diet during Ramadan. Self-titration and monitoring are very essential if insulin is to be used safely. Thank you all for the patient hearing. These are all the references, and I would like to acknowledge our co-authors for this chapter, Professor Wasim Hanif, Professor Mohammad Hussain, Tariq Elad, and Nazir Ahmad. Thank you all.
Thank you very much, Rakesh. It's very clear presentation. It certainly helps that you're a co-author in a number of these studies. So now it's my opportunity to again introduce my good friend and colleague, Dr. Zanaria Hussain. I think you all know her well, but allow me to introduce her again. She's a consultant endocrinologist. She's the head of the service of endocrinology sector in the Ministry of Health and Putrajaya Hospital. She's the immediate past president of the MEMS, as well as being in a number of societies in Malaysia and in the region, and also being very active in a number of research fields, adrenal, as well as, of course, Diabetes and Ramadan, where we've collaborated in a number of papers now, and more to come in the future, inshallah. So the presentation of Dr. Zanaria Hussain is related to the special population, the elderly, the pregnant, those with renal or renal or cardiac problems. Zanaria, over to you.
Thank you very much, Dr. Muhammad Hassanin, and good afternoon to everybody and my colleagues that have presented as well, and my slides are here. So again, I am very grateful the opportunity that we have this event this afternoon as a follow-up to the Diabetes in Ramadan conference we had just a few weeks ago last month, and also the launch of the guidelines. And very, very quickly, Dr. Hassanin has planned the rollout of the workshops as well as the trainer sessions in different regions of the IDF. And again, we are very fortunate that we have the opportunity to have this exposure in Asia today, and hopefully this will impact the contents of the guideline, hopefully will impact on your practice for the coming Ramadan, which is not too far away. And hopefully it will also be noticeable in our standards of care that we may be able to see when we do hopefully embark on the Global Survey 2021. As you know, the Global Survey 2020 has given us much data, including that has been the basis for the recommendations that we've made for this current guideline. So I'm talking on the special populations during Ramadan, and just by the term special populations, I think we gather that these are people who will then have an increased risk of fasting during Ramadan. And these actually encompass the chapters, as I'm sure you have actually had a look, some of you may or may not, at the whole guideline, which is available online. And these chapters are chapter 11 on pregnancy, 12 on the elderly, and chapter 13 that covers cardiovascular as well as renal. Yeah. So it is not much time to go through, but mainly to actually highlight the current practice, standards of care, and maybe the recommendations in the section from the guidelines. Firstly is, of course, better earlier than later to definitely acknowledge the individuals that have been instrumental to develop these chapters in the 2021 guideline, as here on the chapter on pregnancy, fasting in the elderly, as well as Ckd and Cvd. And then this slide, yeah, an important slide that puts into perspective, whether an individual with diabetes will fast or not, yeah. And we recognize that the personal choice of an individual to fast is really quite high. And most individuals with diabetes, whatever their risk category, more often than not, will decide to fast. Yeah, and although individuals with diabetes, as clearly has been mentioned, in the category of those sometimes being unwell, ill, frail, and therefore actually exempted by the Islamic regulations, exempted from fasting during Ramadan, and may definitely be able to compensate or complete this fast at a different time or in a different way. For us then, healthcare professionals, we come into the other circle of actually ascertaining the risk category of these individuals, and therefore then recommending whether these individuals should fast. So under the term medical recommendations, yeah. So also we have heard from my colleague, Dr. Suzyani, about the importance of pre-Ramadan education, following a pre-Ramadan medical evaluation, where we can then assess individual factors in our diabetic patients who intend to fast, and therefore then individualize their education program according to their different areas of need. And this education program, as seen here, should include all these different categories, as you see in the little boxes here in green and blue. But of course, what was really apparent when we looked at the results of the DAR Global Survey 2020 is a large majority of people with type 2 diabetes actually still do not get structured pre-Ramadan education. Yeah, so there is still a need for that. And again, the other thing is how to deliver this in an individualized way. And it's good to see that even now in this COVID era, that the education is actually being addressed in a digital way. So this may be the way forward. Also, this has been alluded to in terms of risk stratification, and there are many elements that have taken into place when deciding on risk. And the amazing thing in the most recent IDF guideline of 2021 is the consideration of multiple risk elements. Yeah, not only the diabetes type, duration, whether the individual has hypoglycemia, their background glycemic control, their types of treatment for glucose lowering, their practices of self-monitoring blood glucose, whether they have had recent acute complications of diabetes, their macrovascular disease, cardiovascular plus renal, and also the presence of what I am actually focusing on, whether they are pregnant, whether they're old and frail, and their physical level of functioning, and also importantly, their previous experiences in prior Ramadans. So you could actually reflect on this in the actual guideline, and there is a scoring system in the risk calculator, and therefore there you can actually place individuals with each element onto a score, and then the cumulative score is then actually reference to a risk categorization, where then you can actually place a person at low risk where there is no harm at all in fasting, and they can go ahead at moderate risk where you would recommend them not to fast, but if they do fast, they need to follow strong medical standards and precautions, and a category of high risk where they do not fast at all. So this is in one slide where you can see just the elements that are picked out here of pregnancy and how the scoring has been set in the guideline or risk calculator. Age is not just taken into account as age, but actually whether they are frail and whether they have any cognitive impairment. And then the chronic complications, specifically cardiovascular disease, whether stable or not, the presence of heart failure, and different categories of renal function. So all this, as I mentioned, would then be scored separately in the elements and would be added together. And again, this traffic light system, which we are quite familiar with, placing people at low risk with a certain score of 0 to 3, a higher risk of moderate risk of 3.5 to 6, and a high risk of score of more than 6. Yeah, and as we discussed, what would be our medical recommendations according to this risk. So in terms of hyperglycemia and pregnancy, just a few highlights. Now, it's interesting because all these areas of special population do not have very much data or evidence to actually provide us with strong recommendations sometimes. But in the area of diabetes in pregnancy, what has been definite and fortunate in lately is the evidence from glucose monitoring and technology, especially flash glucose and continuous glucose monitoring, where it's been seen that women within pregnancy do indeed have better achievement of targets, although the postprandial glucose tends to be a bit higher. And these diabetic women, when fasting, also have asymptomatic periods of hypoglycemia, which can be prolonged and would not be detected otherwise with normal monitoring. And therefore, this places them at risk. Yeah. So we know in these bullets here that pregnant and breastfeeding women are exempt actually to fast, but many of them with diabetes are still wanting strongly to fast. Yeah. So it's important actually to address this, yeah, because we need to actually reduce the adverse outcomes that can happen to both mother and fetus. Yeah. So I've shown you this before with regards to the risk stratification. So pregnancy, if they are within their targets of glucose, and we are reminded even in the even in diabetic who are not fasting, that it is so important to have tight glycemic control, and this also is then necessary during Ramadan as well, so it becomes a challenge. So if they are not within target, the score becomes much higher. Yeah. Again, for these pregnant women, it's important in their earlier pregnancy that a pre-Ramadan assessment is done, and the healthcare provider will then assess whether it's appropriate that this woman, given the right education and also advice on self-monitoring of blood glucose, which definitely needs to be increased, and if possible, even encouraged to have a more sort of intensive way of monitoring glucose, probably with a CGM or a flash glucose, would be also recommended. Yeah, physical activity should be maintained, which is important. The Tarawih prayers that we have at night would add to the extra physical activity, and this should be taken into account for meals and modifications, often of the insulin that they use. Yeah, and nutritional advice, if possible, individualized for the patient who is pregnant with diabetes intending to fast. The targets are very much similar, or actually similar to the non-Ramadan period. As you can see, the tight targets, trying definitely to avoid hypoglycemia, which is anything below 3.9, and to maintain the fasting not more than 5.3. And a tight postprandial target usually taken 2 hours after a meal of less than 6.7. Yeah, and these women should be really strongly informed and educated that they need to know when are the signals to break fast, and this is definitely when they have hypoglycemia, when they are generally just feeling unwell, and of course to actually note the fetal movements. The SMBG should be done, if for the very least, of course, the more the better, before the sunset meal, which is actually just before Ifta, and this would reflect on how they are coping right after a full day of fasting. 1 or 2 hours after meals, as we know, postprandial glucose actually correlates best with pregnancy and fetal outcomes from very established studies in the past. So this would then have to coincide with the 2 main meals, or sometimes even 3 main meals during Ramadan, which are timed differently than the non-Ramadan period. A level that is checked actually in the midday or mid-afternoon, which reflects the risk of hypoglycemia and the glucose trends, whether it's safe to continue the fast right through the end. And of course, whenever they feel unwell, they should actually check their blood glucose. We've had a very good, thorough, comprehensive discussion on insulin just now. And we know that pregnant women, definitely those who have pre-existing diabetes, will go into pregnancy using insulin, whereas those who have diabetes onset during pregnancy or gestational diabetes, some may actually just need diet control, or may even just need metformin or therapy. Yeah? But insulin becomes the mainstay, and definitely it's usually multiple dose insulin or intensive insulin therapy. There may be some type 1 diabetics who are actually on pumps and being pregnant. And personally, I haven't had the experience of managing any type 1 pregnancy in Ramadan. But these, you could actually refer to the guideline, making adjustments to the basal rate so that to minimize hypoglycemia during the fasting period in the day, and possibly to increase the basal rate with the time when there's highest glucose, and also maybe some amount of insulin resistance with less physical activity in the evening after Ifta. And I guess the bolus doses would actually still sort of reflect the insulin to carbohydrate ratios that these individuals practice. In terms of intensive insulin with either analogs or conventional insulins, the basal insulin most often is used once a day. If it's analog insulin, which is a long-acting basal, and if the individual is well controlled, as in pregnancy, they're often well controlled, they would need some reduction in this dose to be taken in the evening after Iftar. And the worry, of course, is hypoglycemia in the day, and therefore the Sahoo dose is usually reduced. Yeah, and the of course not having a meal in the midday, therefore there isn't a need to inject then. And then the Ifta rapid acting insulin is then given. And of course, the advice for at least a 5, if not 7-point glucose monitoring. With the use of human conventional insulin, some may use twice a day NPH. many may still use once a day NPH, and therefore a consideration to adjust the basal dose as well. And with regular human insulin for Ifta and for Sahoo, the same sort of considerations we need to take into account to minimize hypo and reduce the Sahoo dose, and the evening dose may actually need to be increased, especially if the carbohydrates are higher then. And we've also heard about the adjustments of the pre-mix insulins as well. Yeah. And anyway, it's important, as you can see here, a 5 to 7 point blood glucose monitoring is important. So in summary, for pregnancy at least, I think this essentials are education, which is best in the months prior to Ramadan. Ensure that the pregnant lady is actually well informed about their risks, about SNBG and how to break their fast, and adjustments in treatment and lifestyle. This is often important to establish safety and good outcome of fasting as well as of their pregnancy. So when we go on to look at the elderly individuals, and this is also dedicated a whole chapter in the Ramadan practical guidelines. As you know, if you open the guidelines, in the first page of the guidelines is a nice sort of categorization of what is known, what is new, and what is missing, and what we hope we need. And what we hope we need in all these areas of special population is actually more evidence and more research. So what is known about the elderly is, I guess, age alone, of course, should not be used as a risk factor for fasting, yeah, because you can be of different sort of age in the elderly, but you can be more frail or less frail or have some cognitive impairment depending. Yeah, so what we know is actually the elderly with diabetes would definitely have a longer duration of disease. And therefore, in this situation, we'll also then have a higher sort of presence of chronic complications. They may also have some cognitive incline, and their hypoglycemia risk and awareness are definitely compromised. Yeah. So, but we know also from the Ramadan Global Survey of 2020 that many elderly individuals still fast with diabetes. At least with type 2 diabetes, almost 3/4 of those in the global survey above 65 were chose to fast during Ramadan, yeah, and could actually fast for a good number of days. So therefore, being at risk, they really need guidance to make the fasting safe. So what we also know, as I had alluded to in the survey, is even, of course, their rates of fasting, as anticipated, is lower than in those who are younger. And if we place the age sort of cutoff at 65, yeah, we also mentioned about comorbidities and also the risk of complications. Yeah, and therefore sometimes, or importantly, not sometimes, to always look at how medications need to be modified to enable safe fasting and avoid hypoglycemia. What was apparent in the survey was that a very high number of older persons with type 2 diabetes are still using insulin, yeah, when they are fasting, more so than those below the age of 65, which is surprising. And also they are on a significant amount of sulfonylurea. So these are some results that have been summarized from the DAR Global Survey 2020. And as you can see here, those who are older, of more than 65 years, would definitely then almost 3/4 have a diabetes duration of more than a decade. I did mention that, about almost 3/4 fasted. So, a little bit more than a quarter did not fast compared to those below 65. And here is the worry, where we need to have a proper assessment of individuals, very good education and increase monitoring, because their rates of more serious hypoglycemia leading to an acute hospital attendance during the Ramadan was up to 2.5 times higher than those who were less than 65 years old, as you can actually appreciate in the very top sort of bars there. And the risk of complications, we have, of course, anticipated when you're older, longer duration of disease, so more complications. and it's apparent in every category of comorbidity you see, hypertension and hyperlipidemia, and then all the microvascular complications. Also, you see retinopathy and neuropathy and CKD. This is definitely so more than double. And for macrovascular disease of coronary artery disease and stroke and peripheral vascular disease, 1 in 5 actually above 65 have this present, yeah, as well as a doubling of the diabetic foot problems, yeah. So they're coming into fasting during Ramadan with all these comorbidities and macrovascular complications, which could make the Ramadan unsafe for them. So considerations for the elderly with diabetes seeking to fast, we have mentioned that is they do need to have education with regards to how their physical activity needs to be adjusted. They need to have more frequent self-monitoring of glucose, and actually, a large majority of the elderly do not actually measure their blood glucose during Ramadan fasting. And looking at all these other important areas, also whether they have support from family, from community, that can give them more confidence when they actually fast and make sure that it is a safe kind of fasting. So these are just the rates of SMBG, which don't really differ between the different age categories of before or above 65, but what you can appreciate here is whether you're below 65 or above 65, about 3/4 of those in the global survey of type 2 diabetes in Ramadan did not really, 1/4 did not perform SMBG. And many actually did the same frequency of monitoring of glucose, and only 1 in 9 individuals actually practice more frequent monitoring. Okay, so if we look at also the risk stratification tool and we go down to the risk element of frailty and cognition, this is how the risk calculator looks like. If there is no frailty or loss in cognition function, therefore is 0. If you are above 70, but with no home support, so I guess if you do have home support, it doesn't have a risk score, so that becomes 3.5. If you're frail, then it's 6.5 with impaired cognitive function, also 6.5. So these are taken into account with very, very strong scores here, that immediately once you have this score, it already places you into the high risk category. Yeah. And of course, as being an elderly, I think they would have many elements that are positive in the risk scoring, which definitely really makes them have a very high risk of risk stratification. So some of the tips which have actually been highlighted nicely in the guidelines, probably I could not go through it in too much detail in view of time, is the tips on medications and regimens, nicely ensuring that we try to make a definite decision to lower risk towards hypo, whether reducing the medications that cause hypo or to switch to medications that don't cause hypo before Ramadan, whether the switch is temporary or the switch may be permanent and persist after Ramadan. So hypo is the issue, and monitoring more frequently the glucose, yeah. And I guess it might be not accessible to all, but to actually embark on a CGM in the LD might be a bit difficult, but of course, where possible, it is good. The diet, okay, an individualized diet, because they need to keep hydration. The elderly often don't drink enough, they don't take enough proteins and calories as well. So this is important that they keep a good diet and good hydration. And even though physical activity, important that they don't be thoroughly inactive and at least keep up with activity during Ramadan, so that it's important for their overall health. Certain social considerations, we have actually thought about the community and family support and their awareness and education, that they are reminded of symptoms of hypo and hyperglycemia so that they can recognize these, yeah. Okay, so these are just a summary with regards to the elderly that you can, we have actually discussed just now. quite clearly. So I'll go on to the Ckd and Cvd. So in terms of Ckd and Cvd, macrovascular complications are cardiovascular disease, stroke, and peripheral vascular disease, and microvascular complications encompass diabetic kidney disease, neuropathy, and retinopathy. But I guess in terms of Ramadan issue, the main concern is CVD, stroke, and Ckd. So what is known is definitely that diabetes is a risk factor for CVD and stroke. Here, clearly in the sort of first page of the chapter, it's already highlighted that DKD stage 3 is categorized as high risk, and stage 4 to 5 are very high risk, generally once you have this high risk, therefore fasting is not is discouraged and definitely not recommended. And this would be the risk calculator, specifically looking at the element of CVD and Ckd, and you can recognize they take into account the EGFR, the stability of CVD, whether it's symptomatic or not, and also the presence of heart failure. So this is again a box of a standard sort of highlight that is already available in the guideline to remind us that we need a thorough risk assessment from the carer, a diabetes specialist, cardiologist, neurologist, or nephrologist in the situation. And pre-Ramadan assessment, education is very important, and individualized care. Yeah, and appropriate adjustments to their therapies are important. I think there's been mixed sort of evidence for us. We don't know whether Ramadan is associated with a higher risk of cardiovascular events or lower risk. So there've been conflicting evidence. Even with stroke as well, there have been some studies that show there's increase in stroke, and there have some that have not. Yeah. There are evidence though that many risk factors are improved during Ramadan, and therefore potentially it could be a time for protection from cardiovascular events. In terms of Ckd, this is an important area as well. And it's good that the guideline actually has recommendations in this regard. So these are from the guidelines highlighting that there should be a pre-Ramadan assessment well in advance with the education on board. And again, strongly discouraged to fast in Ckd stage 3 to 5. And if the individuals choose to fast, then during the period of Ramadan, they would probably be encouraged to have very frequent reviews, be reminded on hydration during the breaking of fast, after outside fasting, the need to probably monitor the electrolytes and renal function at different points during Ramadan itself, and also regarding foods that they need to avoid in case of high potassium. So the summary of the CVD is such, yeah. Definitely these areas need further research for more strong evidence for recommendations, both in the area of CVD and stroke, as well as in the area of Ckd. Right. So sorry to rush, but I realize that we're short of time, and these are the references that have been used. And I would encourage you to go online and refer to the guideline. Thank you very much.
Thank you very much. That was very clear and robust summary of the special population of elderly, pregnant, as well as those with kidney or cardiac or cardiovascular problems. May I invite the four speakers for taking the Q&A. We already had some questions answered by Dr. Suziani. So perhaps we can all look into the different questions and pick the one that is relevant to all of us or to the individual person. So
there is quite a few on insulin.
Yeah, there are a lot of questions on insulin. So can we start?
Do you want to pick up one, Rakesh?
Yeah. So one of the questions is why for insulin injections we need to adjust the insulin during the suhoor while maintaining the same dose during iftar? Yeah. So the issue was that what we are looking at when you're looking at premixed insulins, or when you're looking at the NPH, use of NPH, then we are worried about the effects of this insulin during the later half of the day, where it could cause hypoglycemia. So we are looking at reducing the dose during suhoor, while we are maintaining the pre-Ramadan dose at iftar, and we are particularly taking the morning dose at pre-Ramadan morning dose as the dose at iftar.
Okay, there's another question about motivating people not to fast.
Yeah.
I think this is a brilliant question because, unfortunately, we are so passionate about fasting and we forget that the Quran and the teaching of the Prophet Muhammad ﷺ include many verses about the importance of protecting our health, protecting our body, not putting ourselves into jeopardy. There is nothing in the religion which advocates harm or potential harm. So if we can talk about this with our patients of the potentials of harm, the risks that they'll be taking, there is no need then for those at the high risk. And that's why we try to make it as intense and individual as possible. It's no longer you simply have a tick in the box to say kidney problems or elderly or type 1. No, indeed, you now have lots of aspects. So the person with a kidney problem, is it Ckd stage 3? What type of therapy they're on? What type of control? Are they monitoring appropriately or not? So many aspects. So potentially, they could be eligible to fast. But on the other hand, someone with seriously advanced kidney or cardiac problem, or someone with hypo unawareness, or frequent hypo, or very poor control, these need to be clear. You're not doing yourself any favors. Plus, the other point, if I were to may say, it is really important that in your regions, in your country, in your city, engage with the religious leaders, because the message of such topic coming from them will reinforce the point of you're not doing yourself religious favors by jeopardizing your health. That's as much as I personally can say on this.
May I just ask you, Dr. Muhammad, so would it be a good thing that we see rates of fasting among diabetics reduce instead of increase? It was interesting that when I was looking at the data from the global survey that, you know, in some countries, for example, Turkey, that the rates of fasting among type 2 diabetics are not as very high as Malaysia. And I was wondering whether this is because we haven't looked at the data, whether maybe their education and their awareness among their HCPs and patients are better. So, you know, is looking at lesser rates of fasting possibly better than higher rates of fasting?
Yeah. I am lucky to have the opportunity to engage with many colleagues and travel to many colleagues among this. I remember doing a workshop on insulin management in Ramadan in one of the countries without naming names. And there was no point for the workshop because all the answers were simply on insulin, do not fast. Okay. So in some countries, they take it strongly that the risk is too high. What is important is to look into the evidence because nevertheless, still in Turkey, Morocco, and Tunisia and Algeria, there are some who fast, and still in many of the countries that push many to fast, such as Saudi Arabia and some other countries, there is a high rate of hypos. So better selection would be helpful for everyone.
Maybe in those with the special populations, maybe these are the ones we need to focus on to make sure that, you know, maybe they don't fast.
Well, you're a co-author, Zanaria, on the type 2, and I was really surprised to see the feedback of 12.6% admissions because of hypo or hypoglycemia in the older group. Yeah. So the exercise really is quite required, is to dissect which older person we should advise. You've fasted, alhamdulillah, so many years, perhaps it's time to think of an alternative for Ramadan fasting. And equally, for someone who is fit and healthy and simply ticking an age group of higher but fit and healthy, there is no problem for them if they wanted to fast.
Dr. Muhammad, there is a question about whether the risk calculator is available
electronically.
In a platform. Yeah.
We are working on it and we are promising to try to get it ready in 2 weeks. We have the huge list of the emails. Once it's ready, we'll email everyone. My advice is keep an eye on the website of IDF as well as on the application of DAR, the healthcare professionals application. And once it's ready, it will be uploaded automatically. The promise I got from the people trying to get it ready is by the end of this month. Probably it will take another week or 10 days to ensure that everything is robust and without hiccups. But nevertheless, you can print this or put it on an Excel sheet in your clinic, and you can do it. Some colleagues are actually going to adopt it in their healthcare systems, where it will be part of like you have the cardiovascular risk calculator, they will have the Ramadan risk calculator, and they're going to work with their own IT department for their electronic data records. So there are lots of ways of including it in the service. I know that Suzyani have answered three questions already. So perhaps, Suzyani, if you felt that one of them is really quite important to verbally say it so that we can share it with other people. While you're thinking, there's a question here on someone asking if baseline glycemic control is bad, which is HbA1c above 9. Is it rationale to maintain the insulin dose for human insulin premix BD and basal bolus analog is not available here? Rakesh, you were with us in the, sorry, that was in type 2. We addressed this point, and in fact, it's indeed part of a future study in Southeast Asia, where the dose adjustments will be tapered according to the level of HbA1c. So what we're saying is, obviously, if someone is terribly hyperglycemic, one, this person is high risk because by virtue they are on insulin, by virtue they are poorly controlled, they should be advised not to fast. If they intend to fast, there is no need to reduce the insulin dose if HbA1c is high. You're going to provide them with an algorithm anyhow. And the algorithm is the ultimate, because if their figures are low, they need to reduce the insulin. If their figures remains to be high, then it's an opportunity to even increase the insulin dose.
There is a question here from an anonymous attendee about why insulin needs to be adjusted during Sahoo while maintaining the dose during Ifta. So I guess generally it would be reduced to minimize hypoglycemia. So we're quite critical to reduce the rapid or the premix insulin at Sahoo, isn't it, Dr. Rakesh? Yeah.
That's precisely what I was trying to highlight, that at Sahoo you're trying to reduce particularly the regular insulin, or even the NPH. If you have NPH, then probably you are looking at reducing that also, because NPH tends to peak in the late afternoon, and you are trying to reduce the risk of hypoglycemia, and we're trying to reduce the dose of NPH also. Whereas for basal insulin, for the long-acting basal analogs like glargine or degludec, we don't have that concern because they don't peak and they have a very flat profile. So we may not need to change their dose, but we definitely need to reduce the dose of NPH also.
There's a question that is related to first day of Eid after Ramadan is over. What do we do with the insulin dose adjustments? And I give you an example from the Ryzodec trial. If I stop fasting, and if I start taking regular means, then I need to go back to my pre-Ramadan insulin dose. That worked, and it's not an issue. If you want to make it in steps, you can, but usually Eid is full of sweets and desserts and celebrations, so certainly hyperglycemia is the essence here, and you want to avoid that. There's one other point that is possibly addressed to all of us. Yes, I'm part of the chapter of the risk category. Who is frail? We couldn't specify who is frail. This is a clinical judgment that every clinician with his patient can decide on that. If you feel that this person is frail, then put him and give him the score of frail. If you feel he or she are not frail, but we cannot really put measures on what exactly constitutes frailty. But I think this is a clinical judgment. What is the thoughts of the colleagues? Suzyani, what are your thoughts? Who is frail?
I was answering a question. So, frail. Well, I think for us, it will be dependent on the patient himself and what's the risk profile like. Yeah, so if somebody who's very good in terms of EDL, then there's not too much of an issue. But I think taking into account all other factors as well. But if somebody who is who will actually need a lot more support in terms of the daily needs, not ADL independent and all that, then I think that will be categorized as somebody who's frail.
Thank you.
Probably,
there are lots of clinical questions, and I would like to highlight that shortly after we finish here, there is Train the Trainer session, which is open for those who registered already for the session. If you've missed registering, there will be another session for Asia, primarily for India, Pakistan, Bangladesh, but certainly if someone from another country wish to attend, they can. So keep an eye on the website, and we'll be announcing this on the event organizer website. So in case, because obviously of so many clinical questions. Rakesh, there's a question for you about the once weekly GLP-1 and pregnancy. Are they licensed and allowed in pregnancy?
Yeah.
Well, I think they're not yet allowed in pregnancy. We don't have the license for their use in pregnancy, but...
yes, exactly. I think we all agree on this. There's a lot of questions.
Yeah. There's a question from my Malaysian colleague here, Dr. Miza. She's asked about rapid-acting insulin dosing, whether it should be 20 minutes before Ifta for high-fat and protein meals. So, I mean, usually that is a question, actually. How you break your fast, do you break your fast immediately with a meal, or do you break it with a little bit? And when to time the insulin at Ifta? That is often something that's quite difficult to address in a practical sense.
Well, as I mentioned, we have the Train the Trainer session starting in 10 minutes with lots of case scenarios that will answer these issues. If you did not register for it, then perhaps keep an eye on the website. We will announce the dates for the other Asia region Train the Trainer session, which will include 5 different clinical cases. With this, I really would like to thank all the faculty for their excellent presentation, the support we got for this presentation from IDF in collaboration with DAR, and indeed the sponsors Sanofi and Servier, and for our organizers, Amber. But mostly the thanks are for you for attending this session, and it's showing the passion for the topic, and I hope we meet up with you again in the future. I know that in the region there is plenty of more diabetes and Ramadan activities, so hopefully Ramadan this year will be much safer. Thank you everyone, and it's a pleasure to have worked with you all. Thank you.